So I'm now going to discuss part 3 of lung pathology. So most often, pulmonary embolism originates from venous thrombosis of the lower extremities or pelvis. So you have learned this in Patho A. It is usually coming from the deep veins of the leg, and the emboli is actually thrown and goes into your lungs. So this is what we refer to as pulmonary embolism. Pulmonary embolism and infarction is an important cause of morbidity and mortality, particularly among bedridden patients and patients with thrombophilia or hypercoagulability. Blood clot can occlude the pulmonary arteries and are almost always embolic in origin. The usual source, as I have mentioned, is usually deep veins of the legs in more than 95% of cases. So the pathophysiologic response will actually depend on the following factors. First of which is the extent to which the pulmonary arterial blood flow is obstructed, the size of the occluded vessel, the number of emboli that's thrown, and the overall status of cardiovascular system, and also the release of vasoactive factors like thromboxane A2. So emboli usually have two deleterious pathophysiologic consequences. The respiratory compromise, which is due to non-perfused, although ventilated segment, and the hemodynamic compromise, which is due to increased resistance to pulmonary blood flow caused by the embolic obstruction. Sudden death may ensue, largely as a result of the blockage of blood flow through the lungs, and that may also be caused by acute right-sided heart failure or acute cor pulmonale. This is an example of an illustration of a somewhat large saddle embolus from the femoral vein, which lodges into the left and right pulmonary artery. So the presence of the emboli will cause occlusion of the blood supply. And on the right-hand side is an example of an infarct. Characteristically, the infarct in the lungs is hemorrhagic. It is wedge-shaped. And when you take sections of which, you will see evidence of necrosis. In the lungs, the usual lodgement, site of lodgement, as I have said, would be the main pulmonary artery or its major branches or at the bifurcation. And this is what we call as saddle emboli. Smaller emboli may travel out into the more peripheral vessels where they may cause hemorrhage or, as I have said, infarction, like the image I have shown you a while ago. So how do we diagnose the disease? If it is a large saddle emboli, it may lead to instantaneous death. ECG may give you electromechanical dissociation. Clinical course, usually there's a large pulmonary embolus, as I have said, in patients with usually the emboli is coming usually from the deep leg veins. Infarcts usually manifest as dyspnea, tachypnea, fever, chest pain, cough, and even hemoptysis. Findings on the chest radiograph may be variable. It can be normal or disclose a pulmonary infarct, usually between 12 to 36 hours after it has occurred, and this will usually appear as a wedge-shaped infiltrate. Okay, let's go to the next, which is disease of vascular origin. Pulmonary hypertension is defined as a mean pulmonary artery pressure greater than or equal to 25 millimeter mercury at rest. WHO classified pulmonary hypertension into 5 groups. As enumerated, you have 5 groups in accordance to WHO classification. Pulmonary hypertension has a lot of causes. it is most frequently associated with structural cardiopulmonary conditions that increases pulmonary vascular resistance, pulmonary blood flow, or left heart resistance to blood flow. Some of the more common causes are the following. One is it can be caused by obstructive sleep apnea. It may also be idiopathic. So let us take a look at it one by one. So chronic obstructive or interstitial lung disease, pulmonary hypertension. One example I can give is obstructive sleep apnea. This is due to obesity and hypoxemia, which may cause significant contributory factors to increase vascular resistance and eventual pulmonary hypertension. Chronic obstructive or interstitial lung disease. These diseases will obliterate alveolar capillaries. And when this happens, it will then increase pulmonary resistance to blood flow and secondarily, pulmonary blood pressure. Heart diseases, like for example, mitral stenosis, will cause an increase in left atrial pressure and pulmonary venous pressure, eventually transmitted to the arterial side of the pulmonary vasculature, leading to hypertension. Recurrent emboli may cause pulmonary hypertension by reducing the functional cross-sectional area of the pulmonary vascular bed. Autoimmune disorders, usually in the form of systemic sclerosis, may involve the pulmonary vasculature, leading to increased vascular resistance and hypertension. It may also be idiopathic. When you say idiopathic, it is in which all known causes are excluded. And so this is what you refer to as idiopathic. 80% of idiopathic pulmonary hypertension, often referred to as primary pulmonary hypertension, has a genetic basis. It is inherited in families as an autosomal dominant trait. So what is happening in the vessels? Regardless of the etiology, all forms of pulmonary hypertension are associated with medial hypertrophy of the pulmonary muscular and elastic arteries, pulmonary arterial atherosclerosis, and eventual ventricular hypertrophy. The presence of many or organizing or recanalized thrombi favors recurrent pulmonary emboli as the cause, and the coexistence of diffuse pulmonary fibrosis or severe emphysema and chronic bronchitis, if this is also present in your patient, may lead to chronic hypoxia as the initiating events. In this illustration, the vessel changes can involve the entire arterial tree, from the main pulmonary arteries down to the arterioles. In most severe cases, the atheromatous deposit form in the pulmonary artery and its major branches, resembling systemic atherosclerosis. The arterioles and smaller arteries are most prominently affected, and they will usually present with striking medial hypertrophy and intimal fibrosis. So patients with pulmonary hypertension is most commonly women. They are 20 to 40 years of age, and it is also seen occasionally in young children. Clinical signs and symptoms in all forms of pulmonary hypertension become evident only in advanced disease. In cases of idiopathic disease, the presenting features are usually dyspnea and fatigue, but some patients may have chest pain of the anginal type. Over time, respiratory distress, cyanosis, and right ventricular hypertrophy occur, and death from decompensated pulmonary cor pulmonale. Now, the next part of the discussion would be focusing on diffuse pulmonary hemorrhage syndrome, and the first on the list is Goodpasture. Goodpasture is an autoimmune disease. It is usually you're looking at two organs. The first is the kidney, and the other one is the lung. So again, you look for two organs. One is the kidney and the other one is the lung. It is due to circulating autoantibodies against the non-collagenous domain of the alpha-3 chain of collagen type 4. When only renal disease is caused by this antibody, it is called antiglomerular basement membrane disease. The Goodpasture syndrome designates the 40 to 60% of patients who develop pulmonary hemorrhage in addition to renal disease. So again, pulmonary hemorrhage and renal manifestation. So how do you diagnose that? Of course, X-ray is again needed. Usually, the form of renal disease is basically what we call as glomerulonephritis. In the classic case, the patient will usually present with lungs that are heavy with areas of consolidation. There is focal necrosis of alveolar walls and it is associated with intraalveolar hemorrhage. On the other hand, for the renal, it is again, as I have mentioned, in the form of glomerulonephritis. Particularly, the kidneys have either the characteristic focal proliferative glomerulonephritis or crescentic glomerulonephritis, which may progress to rapidly progressive glomerulonephritis. The second on the list is what we call as idiopathic pulmonary hemosiderosis. And the third would be your vasculitis-associated hemorrhage. In all of the three, you would expect the presence of areas of hemorrhage in the lung parenchyma. So let us go now to pulmonary infection. Pulmonary infection occurs because you have a defense system that somewhat is low, an injury to the mucociliary apparatus, which may be initiated by a hobby, like for example, cigarette smoking, which actually transforms or causes metaplasia in your lining epithelium from columnar to squamous, or you have accumulation of secretions or interference with phagocytic or bactericidal action and pulmonary congestion and edema. So when we're talking of pulmonary infection, there are a lot of agents, as you can see. So how do you diagnose the disease? Community-acquired acute pneumonia is referring to infection that is otherwise occurring in healthy individual, acquired in the normal environment. It may be bacterial or viral, but then again, to diagnose it, you may have to do radiologic examination, X-rays, and you can actually identify the presence of the organism by doing culture. So this 1 to 4 is an example of common agents that may be isolated. Additional agents are as follows. So what is usually the culture? The culture is often using sputum or pleural fluid. It may even be blood for patients in which you are thinking of disseminated or septicemia. You can also use blood. So often it is sputum, pleural fluid, it can also be bronchial lavage or specimen. Let's say the patient died. So if the patient dies of pneumonia, the pathologist will have to check the lungs, and on autopsy, we are expecting two types of consolidation. One is called patchy. The image on the left is called patchy consolidation. The white areas that you see are irregularly distributed. Or it may be that the consolidation is involving the entirety of the lobe, as you can see here. So there are two patterns of distribution. It may be patchy or it may involve the entire lobe. So there are actually two terms that are used, lobular and lobar. So for patchy consolidation, you have lobular, and then of course for the entirety of the lobe, you have what you call as lobar. Now, so as a pathologist, you take sections of the autopsy and then you examine it under the microscope. And if it is lobar, you are to see either of the 4 stages. So lobar pneumonia has 4 stages. You have congestion, red hepatization, gray hepatization, and resolution. So these are the 4 stages of inflammatory response that are classically associated with lobar pneumonia. It is called as hepatization because the lung assumes a liver-like consistency. The red here should remind you that microscopically, there is confluent exudation of red blood cells. Okay, that's why the color is red. And the crepitancy is lost. That's why it is called hepatization. In time, eventually, the red cells will disintegrate so that what remains would be the exudate. So you change. The color grossly changes from red to gray. But then again, there is still that solid consistency, hence the retention of the term hepatization. Should your patient respond to treatment, eventually the macrophage will engulf those exudates and eventually you go back to normal. So let us try to analyze this illustration. So this is an example of lobar pneumonia, consolidation of the lower lobe, and this is an example of that of normal. Now, as you can see here, you have exudates that fills up the alveoli, and in here, there seems to be a retraction of the exudate surrounding the alveoli. So this is an example of red hepatization going into gray hepatization. So as I have mentioned, you need to do culture. When you cannot control, the culture will actually tell you the type of organism that you are facing. I have enumerated a while ago the most probable possibilities. The culture will also tell you what are the antibiotics that will work best. The exam is actually what we call as culture and sensitivity. The sensitivity will tell you what is the best antibiotic to use, because if it gets to be uncontrolled, then you develop the complications of bacterial pneumonia, which may be in the form of, from a pneumonia, it can go into a localized abscess. It can actually spread outside, first into the pleural cavity, and that's what we call as empyema. At this point, you may have pleural fluid accumulation. You can aspirate this, take a sample of which, submit this again for culture and sensitivity. Or it may be disseminated via blood. It can go into different organs, as you can see in the third bullet. So if you cannot control the sensitivity pattern, will tell you what is the best antibiotic to give, as I have mentioned. But then again, if you cannot control, then these are the most likely sequelae of complications expected. Now, there is another group which is termed as community-acquired or atypical. It is called atypical because often patients do not have copious amount of sputum. You do not have the consolidation that I have shown you a while ago, and usually the white cell count is not that high and there is no exudate. These are the common organisms implicated. So it may be viral, it may also be bacterial. But one of the common things that we usually see on autopsy is the presence of what you call as hyaline membrane. The usual etiology of atypical pneumonia. So hyaline membrane is here in this illustration. That's the pinkish material that lines the alveolar walls. So the usual involvement is patchy. The usual type of inflammation is it's in the interstitium. And as I have said, you may see pinkish hyaline membrane lining the alveolar walls. The usual cause of pneumonia for a typical type or a typical group would be your viruses. So the next few slides is a rundown of the possible viruses that may have caused the disease. First on the list is, of course, influenza. It is a single-stranded RNA virus bound by nucleoprotein, which actually determines the type, whether it's influenza A, B, or C. This virus is capable of what we call as antigenic shift, and the first one is what we call as antigenic drift. Take note of the word epidemic and pandemic, because these are basically things that you should remember. Why is it happening? because the virus is capable of antigenic shift and antigenic drift. There are, as I have said, it is a single-stranded RNA virus. There's a lipid bilayer envelope. So culture is difficult for viral agents, but it is possible, but it is basically done on laboratories with restrictions basically at biosafety level 4. If the easiest way to diagnose it, which is already available in the market, is via RT-PCR. So RT-PCR is a machine which we use to detect the presence of whatever is the RNA. Let's say in this case, it's ssRNA. This is detected utilizing the sample taken from the patient. So another one is what we call as human metapneumonia or human metapneuvirus. This is usually, again, transmitted via aerosol. It is belonging to the paramyxo virus. You have also your SARS, which is, again, coronavirus, related basically to the cause of our current pandemic. SARS appeared in November 2022 in Guangdong province of China and subsequently spread to other countries. Usually, again, this is a respiratory route of infection. So the agent is expected to spread from person to person via respiratory aerosols. And when you do an autopsy, there is usually mucosal hyperemia and swelling. Lymphos, monocytic, and plasmacytic infiltration of the lung parenchyma is also expected. Now, the detection of the virus, as I have said, can be in the form of PCR. Now, the problem with, there's also this healthcare workers like us, is that, of course, we are exposed, but for patients, this particular slide refers to patients admitted. They did not came in with pneumonia, but then again, as they are hospitalized, we detected that there is pneumonia happening in your patient. So hospitalization of at least 2 days within the recent past is a important history that you should look into. It may also occur in nursing home facility, and hemodialysis clinic, or patients with IV antibiotic therapy, which may actually connote contamination. Now, so hospital-acquired nosocomial pneumonia is, again, another category, which is expected to be pulmonary infection acquired in the course of the hospital stay. These are very common among patients that are immunosuppressed. Again, to diagnose it, you can do culture studies, as I have explained a while ago, to determine the particular causative agent. Let's say your patient is debilitated, stroke patient, or patient with repeated vomiting. The possibility of food particles lodging, as I have said in the part 1 lecture, more likely on the right side for foreign body lodgement, will then predispose your patient to have pneumonia. And if this is the case, occurring in the background of abnormal gag or swallowing reflex, this is what we call as aspiration pneumonia. Typically, more than one organism is recovered on culture, and usually they are commonly anaerobic organism. The usual presentation would be that of necrotizing type, so that when you look at it under the microscope, lung abscess is a common finding that you would see. The next group would be your chronic pneumonia or granulomatous inflammation caused by fungi. So when you say chronic pneumonia, the usual agents that we are talking about here would be your fungal organisms. Like, for example, your histoplasmosis is first on the list. Histoplasmosis, the transmission is caused by dust particles from soil contaminated with bird or bat droppings. that contain your small pores or your microconidia. So these are again engulfed by your macrophages. So as this is, there are other agents that are also implicated. Next would be, on the list, would be your mycosis. Okay. So blastomycosis is again a dimorphic fungi. And usually, again, you'll have the symptoms of cough and chest x-ray. So how do you diagnose the disease if it is fungal organism? You can actually do culture of fungal or fungi, but it takes weeks. So often, if you are entertaining that it is a fungal etiology, the easiest is a sputum KOH, in which you are to see either the yeast cells or the hyphal elements. It can also be that if it's tissues, you employ a special stain, like for example, Gomoris methanomin silver stain, will highlight the presence of hyphae or yeast in your sections. Okay. So let us go now to the next group, which is lung abscess. Lung abscess means a local suppurative process that produces necrosis in the tissue. The etiology of which, again, are basically the same as that of pneumonia. So you have to do culture studies again. And X-ray. X-ray would show you that the localized process is actually often confined in one lobe, and it is often in the lower lobe in most cases. Now, the causative organisms can, as I have said, it can be a complication of your pneumonia, uncontrolled by antibiotics going into lung abscess. But there are also other causes implicated, like neoplasia or traumatic injury to the lungs. By abscess, it means that the suppurative inflammation, if you will recall from your patho A, suppurative inflammation will then digest the lung parenchyma. So you end up with cystic cavities. The cavities is expected to contain pus or suppurative material. So your patient is expected to have copious amount of foul-smelling, usually purulent serosanguinous sputum that can then be subjected for, again, culture and even gram stain. Now, I'm mentioning gram stain because this is one of the easiest way to diagnose what is the type of organism you are entertaining. Culture may take 3 to 5 days. However, gram stain, the result of which can be released within the day. So usually it takes only an hour or two for the medical technologists to interpret it. So short to say, you will already have an idea whether you're looking at gram-positive or gram-negative organisms and start with the empiric therapy of your patient. So that's our discussion for lung infection. Now, lung transplantation is usually indicated, or indication for transplantation may include almost all non-neoplastic terminal lung disease, provided that the patient does not have any serious disease which would preclude lifelong immunosuppressive therapy. The most common indications are already enumerated. So when bilateral, for example, when bilateral chronic infection is present, like in patients with cystic fibrosis or bronchiectasis, both lungs of the recipient must be replaced to remove the reservoir of infection. With improving surgical and open organ preservation techniques, post-operative complications are becoming rare. The transplanted lung is subject to two major complications. What we have is actually either the problem that you will usually encounter will usually be in the form of rejection, that is one, or basically the rejection or infection. So the usual would be infection or rejection. Usually, pulmonary infection arises on a background of immunocompromised host. Rejection, on the other hand, may be acute or chronic rejection. Acute rejection most often appears several weeks to months after surgery, but it may also be present years later or whenever immunosuppression is decreased. Chronic rejection, on the other hand, is usually occurring 3 to 5 years post-transplant. Okay. So let us now go to the tumors of the lungs. Lung cancer is regarded as the most frequently diagnosed major cancer in the world and the most common cause of cancer, one of the most common cause of cancer mortality. Now, there are different risk factors for lung cancer. When I was discussing pneumoconiosis, we somewhat touched on tobacco smoking and industrial hazards. Okay. Tobacco smoking, industrial hazards, like for example, what's listed here that we have tackled is asbestos. It can also be something that is in your genes. For example, oncogenes or CYP1A1. Radon is the pathogenic mechanism is believed to be due to inhalation and bronchial deposition of radioactive decay products that become attached to environmental aerosols. P53 is known to be common to both small cell and non-small cell carcinoma. CMYC, okay, and retinoblastoma is common in non-small cell carcinoma. RAS and P16 are common in non-small cell carcinoma. And people with certain alleles of CYP1A1 have an increased capacity to metabolize procarcinogens derived from cigarette smoke and conceivably incur the greatest risk of developing lung cancer. So when we go to precursor lesions of lung cancer, these are the usual, from the sequence of metaplasia, dysplasia to carcinoma, or atypical adenomatous hyperplasia to AIS, or basically your neuroendocrine cell hyperplasia. Adenocarcinoma is often seen in women, and it is usually not associated with a history of smoking. If you will go over your book, there are a lot of malignancy enumerated there, but I have arranged it in such a way as to the most common going into the least common. So as you can see here, the most common will then be squamous, followed by small cell, followed by adeno, large cell, and the others. So in any type of malignancy stated, the first thing to do is to establish where is the mass. So when you're looking at a patient with lung malignancy, you are then to see first or establish first the location of the mass. And how do you do that? You can do radiographic studies like simple X-ray. If the mass is big, it's already visible. But if it's small, you may have to do CT scan studies for better visualization. When you see it, that it is like here, this is your trachea and that's your right and left bronchi, and the mass is here. This is often what we call as central in location because it is along the central airways. But as you can see in this unfortunate patient, it is already extending into the periphery of the lung. So what is the usual treatment? If it is surgically resectable, you may end up with lobectomy. So it may be central, it may be peripheral in location. To diagnose it, for example, before you do the lobectomy, what can you do? One is you can actually do a bronchoalveolar lavage in which an endoscope is inserted here, NSS is used, and then there is a brush right at the tip of the scope. So first you wash it. That's what you call as bronchial washing. Second is you try to scrape through it, and that's what you call as bronchial brush. So neoplastic cells, if you will recall in patho A, tends to be non-cohesive. So this specimen, the cytology specimen, the bronchial wash and the bronchial brush, is expected to contain the presence of the malignant cells. That's one thing, one way to diagnose histologically or cytologically. One is, the other way is via tissue diagnosis. And how do you do that? Let's say, for example, this mass, it's already in the periphery of the lung. So you can actually aspirate. CT scan guided biopsy can be done. So the needle is inserted, pierced through the mass, and you get a large bore needle. So you get to sample the mass. So that core biopsy can be subjected to histopathologic studies, and the pathologist can confirm then what is again the type of the mass. So the diagnosis of pathology before lobectomy can be in the form of cytology or histopathology. When we are diagnosing malignancy, clinicians, particularly pulmonologists, are expecting us to basically identify whether we're looking at small cell or non-small cell carcinoma. Small cell, you will see in the images later, characteristically is called as such because all you see are round blue cells. But prognosis-wise, they are basically bad news. So among the pulmonologists, it is important for the pathologist to commit whether they are looking at small cell carcinoma or non-small cell carcinoma. So if you're going to put it up again here, so small cell belongs to this category. So the rest, like squamous, adeno, large cell, and the others here on this slide, are all then falling into what we call as the non-small cell carcinoma group. Okay. Now, that being said, you as the clinician will have to take a look at the patient. And of course, these are the most common manifestations that you will more likely see. So the lung carcinoma can then be, after the tissue biopsy is done, so our intent is for the pathologist to classify it histologically. That's why it is termed histologic classification. As I have mentioned, generally speaking, we call it either as small cell or the rest belonging to the non-small cell group. So let's try to go back here. This is because prognosis-wise, it is important to distinguish. Now, so lung carcinoma are often, again, if it's in the hilus of the lung, like the image I've shown you, that's central. But it can also be along the periphery of the lung, and that is peripheral in location. They tend to grow and encroach the parenchyma, as you can see in the image above that I have explained, and they tend to spread. So usually, these are the common sites of spread hematogenously. So one of the most important to study is particularly your squamous cell carcinoma. They are characteristically giving you what we call as evidence of keratinization. When you say keratinization, it takes the forms of squamous pearl. So these are examples of squamous pearl. So on biopsy, tissue biopsy, you're expecting to see this. But what if what we use is for example, cytology, like sputum or bronchial washing or bronchial brushing? Then the images on the right are examples of cytologic examination. So this time you're studying fluid specimen or bronchoalveolar lavage specimen. And just the same, you will be able to diagnose, or the pathologist will be able to diagnose that the cells are malignant. How? You remember neoplasia? Characteristically, they are enlarged, hyperchromatic. They are of differing sizes and shape. They are very pleomorphic. very blue. That's why it's hyperchromatic. The chromatin pattern is expected to be coarse. And the evidence of keratinization, if this is on tissue, on cytology would appear as orangophilic cytoplasm like this. So as you can see here, the one being pointed at is actually an evidence of keratinization on cytology. They will appear as atypical cells with markedly eosinophilic dense cytoplasm. Okay. So this is an example of genetic analysis that you can do also. But often in our country, the practice is you see the mass, the intervention radiologist will get the sample, pass it on to the pathologist who is supposed to do the histologic diagnosis. When the report is out, pass it back to the pulmonologist who is usually with a partner, a thoracovascular surgeon. If resection is needed, then they will then resect the specimen. And then we get the actual lobectomy. So, other type that's common is adenocarcinoma. It is, from the term itself, you will see that this time you are expecting glands. Okay. So this is usually more than 75% of which are associated with what we call as KRAS mutation. More than 5% seen primarily in adenocarcinoma, with a much lower frequency in non-smokers and smokers. You also have P53. Let's pull that up. So this one. So it is usually associated with smoking, but a lesser degree compared to squamous. You have TTF1 is a special stain that you can do on tissue sections. It is a particular marker for glandular configuration, which is, of course, seen in adeno-CA. As you can see here, these are glands. So if this H&E tissue is subjected to TTF1, it is expected to be positive, and the positive result of which is brown coloration. Genetic-wise, you can do assays like EG, molecular basis, EGFR, KRAS mutation, P53. So, they are often in the periphery. A while ago, I was showing you a lesion that is central in location. This is an example of a lesion that is now peripherally located. So again, you can aspirate that, and the glands are expected to be like this, telling you that it is adenocarcinoma. You can, if, for example, there's fluid accumulation here, pleural fluid accumulation, secondary to the presence of the mass, it is sometimes expected, or it is expected, that pleural fluid accumulates on the background of malignancy. So that pleural fluid can also be aspirated, and that cytology sample of the pleural fluid, you can actually look for, again, evidence of tumor. And in this case, you are now looking for glandular configuration, which is right at the bottom. So this is an example of adenocarcinoma on cytology. So again, this is peripheral, and usually they are nodules. Sometimes they try to line the alveolar walls, and this is what we call as the lipidic pattern. Another more common is small cell. Small cell, on the other hand, is called as such. As I've said a while ago, it's very important to determine small cell or non-small cell. It is called small cell because, let us go down now to the image. They are characteristically small epithelial cells. They have very scant cytoplasm. The cell border is characteristically described as salt and pepper, or the pattern. The nucleoli is expected to be inconspicuous. They do not give you glandular or squamous organization. Instead, you all see blue cells. That's why they are called as small cell carcinoma. One thing that you should remember about small cell is that they can secrete Okay, they have hormones. They can actually secrete hormones because they are believed to arise from neuroendocrine progenitor cells or epithelium. They secrete hormones so that this may actually be the manifestation of the patient. I'll show you a little later of possible manifestation. The mutations are usually of the P53 type. Now, the other is what we call as large cell. Again, from the name itself. Why? Because they appear as such. They are usually organoid, nesting, trabecular, palisading, solid sheets. They are undifferentiated. So that's why they are called as large cell. So those are the common malignancies encountered. In time or in some patients, you may see two patterns. So when you see two patterns, this is what we call as combined carcinoma. So again, do not forget, the most common would be cough as the manifestation. It tells you that there's involvement of the central airways. Sometimes your patient may have hemoptysis, meaning there's already hemorrhage from tumor in an airway. Chest pain is sometimes also appreciated. It may connote invasion of adjacent structures like mediastinum, pleura, or chest wall. Diaphragm paralysis, yes, for phrenic nerve involvement. Horner is indicating, Horner syndrome is indicating sympathetic ganglia invasion. It may also be chest wall invasion of your ribs. So, lung carcinoma is then the diagnosis. Next step, when you talk to your patient, is to prognosticate. This is an example of slide of prognostication. You will tell the possible response rate to surgery, to radio or chemotherapy, and usually the patient will ask you how long. So this is the time of, so after you're done with as I have mentioned a while ago, the surgeon is usually with the pulmo. And when the histopathologic report is released by the pathologist, the surgeon and the pulmo will then do staging. After doing the staging, I have placed it here. Okay, so this staging, you will then be able to know what is the more likely prognosis of your patient. And should you need additional treatment, like for example, radio or chemotherapy. I told you a while ago that there are tumors that will actually secrete hormones. So for example, these are examples of hormones that are commonly seen in lung carcinoma and the expected manifestation. So for example, hypocalcemia for calcitonin, gynecomastia for gonadotropin. They may actually have other systemic manifestations too, like this. So Lambert-Eaton is a muscle weakness. It is caused by autoantibodies directed to the neuronal calcium channel. You may have clubbing of fingers. This is what you call as hypertrophic pulmonary osteoarthropathy. The apical lung cancer in the pulmonary sulcus tend to invade neural structures and around the trachea. So Horner syndrome may be seen. What are the components again of Horner? Enophthalmos, ptosis, meiosis, and anhidrosis are common things that you can see. Now, there's also what you call as neuroendocrine proliferation and tumors. So it's categorized actually into the following. The first on the list is benign tumorlet. The second would be your carcinoid tumors. So carcinoid tumors are usually appearing as intraluminal mass, like 3 to 4 centimeters in diameter. Let me show you that image. So this one. And usually, they are classically described as collar button lesion. This is an example of organoid or trabecular arrangement. It's actually here, organoid trabecular rosette-like arrangement of cells separated by delicate fibrovascular stroma. So this is an example of organoid or trabecular arrangement. So when you diagnose carcinoid, it is important for us pathologists to say if it is atypical or typical. And how do we do that? We have to count the number of mitotic figures. Is it less than 2 or is it more than 2 per 10 high power field? We have to observe for evidence of atypia, lymphatic invasion, cellularity, nucleoli. And if this is present, then we then categorize it as atypical. Why? Because prognosis-wise, it is also, again, very important. Now, there are also miscellaneous tumors, like, for example, hamartoma, inflammatory, myofibroblastic tumor, are examples of miscellaneous tumor. So, we have now resected the specimen, if you're following my line of discussion, and we are now going on the phase of reviewing how to do the staging. So let us go here. So even before you operate on the patient, you somewhat already have an idea of the size. And that is actually what you look for in T. So, but a more accurate measurement of the mass should be provided to you by the pathologist, particularly when you do a lobectomy or a specimen. Next stage would be N. So the size of the mass is important, as well as the extent of involvement of adjacent structures in your chest. Like, for example, the mediastinum, the pleura. Okay. Now, if it happens, then it may be either T3 or T4. Next is you assess the nodes. The nodes can be, you have to know if, so how do you do this? You can do again CT scan, bone imaging, or CT scan findings. Will tell you if there are enlarged nodes, or in the lobectomy sample, the pathologist, as it is being dissected, may be able to isolate lymph nodes. And if the pathologist is able to isolate lymph nodes with evidence of metastasis, then it then automatically puts it either N2 or N3, depending on where is the location of the node. Now, you have to do a total body scan. Look for the liver or check the liver. You can actually check the intestine also. I mean, total body scan implies that you are looking for distant metastasis. So the liver is one of the most common organ to look for. If that happens, then it's either distant metastasis is not detected or it is actually present. So depending on whatever T, N, or M you were able to collate, then you will be able to then stage your patient accordingly, either stage 1 to stage 4. Okay. So we are now on the mediastinal tumors, and what do I want you to remember here? Mediastinal tumors, very important to diagnose it. You have to know what is the location, anterior, superior, middle, posterior. Because in like any other organ, they will actually appear the same. Another one is metastatic tumor. Often, like the liver, lungs is the most common site of metastatic neoplasm. But often, if it is metastatic to the lungs, characteristically, you will see it as multiple nodules like this. This is what we call as cannonball lesion. They are usually scattered all throughout the lobes. So this is what we call as cannonball lesion. So to diagnose, again, you can do a scan, insert a needle here, get a tissue sample, and say, for example, this is coming from the colon or the breast, then the pathologist will be able to tell you that if it is a primary or a metastatic tumor. So we go now to pleura. So for pleura, we have accumulations of fluid. I have already mentioned this somewhat a while ago. It can be neoplastic in origin. It can actually be infectious in origin, like, for example, your pneumonia. It can actually be collagen vascular disease like SLE, but as I have said, it can also be tumor. So either which, you aspirate the fluid. So when you aspirate the fluid, you usually look for or do test on it. And you will then be able to, so the usual is you do a cell count, a diff count. You also do chemistry analysis like protein, LDH. And that being said, you will then be able to, together with the correlation of your history and physical exam, you will then be able to classify whether your pleural space fluid accumulation is non-inflammatory or is it inflammatory in nature. So that is what is meant by that. Is it inflammatory or is it non-inflammatory in nature? Of course, before you do that, it is but normal for you to see it first using radiographs. And another thing that accumulates, of course, can also be air. And this is what we call as pneumothorax. So again, you do radiograph. What do you see? Do you see air? That's pneumothorax. Do you see fluid? You aspirate. If you aspirate, you do laboratory exam that will then differentiate whether you're looking at inflammatory or non-inflammatory or tumor for that matter. If you're looking at tumors, so the next question that you should ask then is the tumor lungs primary or is the tumor primary pleura? Because there are also pleural tumors. Like for example, this is an example of a tumor in the pleura, which we call a solitary localized fibrous tumor. They are characteristically 1 to 2 centimeters in diameter and they are attached to the pleural surface. On the other hand, this is an example of a malignant tumor, okay, which is called as malignant mesothelioma. Malignant mesothelioma is an important tumor because it actually arises or it is encasing your lung. Let me show you the image first. This is an example of mesothelioma. So it encases your lung, and the most common histology would appear as glands, as you can see here. So the next question would be, am I looking at mesothelioma or am I looking at adenocarcinoma? So malignant mesothelioma can actually be of two types. Epithelioid type, which looks like glands, and the other one would be your sarcomatoid type. Okay, let us take a look at that. Again, malignant mesothelioma, sarcomatoid type. Okay, so this is epithelium-like or mesenchymal. Epithelium-like or epithelioid type is 60% of the tumor, but it resembles that of adeno. So the next question is, or is this the sarcomatoid type? Or do you see both in the same mass, meaning it's the mixed type? So say, for example, it's the epithelioid because it's the more common, as I have said. So your problem now is, am I looking at adenocarcinoma of the lungs or am I looking at a malignant mesothelioma epithelioid type? So this slide enumerates what do you expect in an epithelioid type of malignant mesothelioma. So how do you do this? For example, you see glands. Balik tayo dito. So you see glands. You perform then the immunostain. So say the immunostain that you requested is keratin. If keratin is positive, which in this case, this is how it appears as positive, it is brown, then that tells you that you are looking at malignant mesothelioma or adeno-CA. Now, which one favors the other? So, this is an example of what I'm trying to explain. The different stains will tell you if it is favoring mesothelioma over adenocarcinoma. So you can request for CEA, you can request for keratin, and the expected results are stated. Or you can also do electron microscopy, because for electron microscopy, if it is long microvilli that you see, this is an example. So this is long microvilli. So that tells you that this is, if this is what you see, then the tumor is then malignant mesothelioma. If you see that it is small, short, and blunted like this, then the tumor, the glandular forming tumor, is then a pulmonary adenocarcinoma. So that ends the chapter. I hope you were able to learn something. And if you have any questions, feel free to reach me. Thank you very much for your kind attention.